Okay, we ready to finish out our very, very new stuff? Tomorrow is going to be very familiar with trauma.
No, really, I'm not.
Okay, so in the body. Oh, well, there's no room. I'll draw it in a minute. The kidneys sit right about here. Okay, the right one is a little. Wait, which one is it? Is it right one's lower? Yeah, because of the liver. The right one sits a little lower than the left kidney. Okay, the kidneys sit at about a 30-degree angle from the mid-coronal plane. Okay, so about 30 degrees backwards. That's why the body's rotated about 30 degrees in an oblique direction either way to place one kidney perpendicular to the IR and to place another parallel to the IR. Make sense? Questions?
Can you say it one more time? I'm sorry.
I'm just going to read this line. The body's rotated about 30 degrees in each direction to place one kidney and then the other parallel to the IR, and a 30-degree RPO will place the left kidney in parallel. So 30 degrees here, place the left kidney parallel. Okay? Each kidney is surrounded by a mass of fatty tissue called adipose capsule. That's also my stage name. Or perirenal fat. Kidneys and the ureters are retroperitoneal structures, and the bladder and the urethra are intraperitoneal structures, okay? Very important for your registry notes. The registry loves to ask you if the kidneys are retroperitoneal structures. Yes, they are. The kidneys normally lie about halfway between the xiphoid process and the iliac crest, so about right here, okay? The kidneys lie about 1 centimeter more superior, the left kidney is 1 centimeter more superior than the right kidney. The top of the left kidney is usually at the level of T11 and T12. Bottom of the right kidney is at the level of the upper part of L3. Okay? The kidneys drop farther than those positions is a condition called nephroptosis. If it helps you remember that, nephrop, drop. Okay? 3 points of constriction along the path of the ureter. The UPJ, the pelvic brim, and the UVJ, okay? The ureteropelvic junction, this is where the ureter meets the renal pelvis. The pelvic brim, this is where the ureter crosses over the actual bony brim of the pelvis. And the the ureterovesical junction, UVJ, is where the ureter connects to the postero-inferolateral part of the bladder, okay? Great. Love it. Types of contrast media that we use. Do we use barium for interrogation of the genitourinary system? Good God, no. We don't. We use water-soluble contrast, most often non-ionic because it's going to cause less reactivity or less reactions, okay? Although ionic contrast does still exist. I will read these two subsections about ionic versus non-ionic contrast. I want you to have a very passing familiarity with these, okay? The cation dissociates from the parent compound or anion, thus creating two separate ions in the blood. That's why it's called ionic contrast. It dissociates into ions, okay? The non-ionic contrast contains no positively charged cations. Contrast medium remains intact, meaning it doesn't break down into ions, okay? That is the main takeaway that you need to have from that. Never to be seen again. Common side effects of having iodinated contrast media injected into the vascular system. You will have a metallic taste in the mouth and a temporary warm, flushed feeling over your body, okay? I told you guys my story about the CT tech who got flustered that one time, right? When he had a trauma situation in CT. And he had one thing that he said every time. Warm feeling in the body, or warm feeling in the pants, metallic taste in the mouth. But this time he got it backwards because he was flustered. Metallic taste in the pants, warm feeling in the mouth. Hilarious. Blood chemistry. Yes, you need to know these. Commit them to your memory. You need to know creatinine and blood urea nitrogen. Creatinine range normal, 0.6 to 1.5 mg per deciliter. Okay? BUN, blood urea nitrogen, the range is between 8 and 25 mg per 100 deciliters, or milliliters, excuse me. If you have a patient who is diabetic and they are taking metformin hydrochloride, that is a drug that is given for the management of non-insulin dependent diabetes mellitus. So the recommendation for patients who are taking metformin is that they withhold that metformin medication for 48 hours after the procedure so that we don't cause them to have any issues from the reaction of that contrast with the metformin. Okay? Anytime you give iodinated contrast media to somebody in any way, I would say, make sure that a fully stocked crash cart is nearby, because it's surprising and terrifying how quickly somebody can go from, I have an itchy feeling in my throat, to full code very quickly, okay? Especially if it's given into the venous system. So epinephrine should be available, as well as Benadryl or diphenhydramine, okay? Epinephrine should be available along with a syringe and needle ready to use, blood pressure support for allergic reactions, vasoconstriction to treat any asthma attacks. If we're worried that a patient will have a reaction or has a history of reaction, we can pre-treat them with a combination of Benadryl and prednisone, which is a steroid. It's given over a period of 12 hours or more before the procedure. Okay? Categories of contrast media reactions. I know we've talked about this before. It goes from mild to severe, mild and non-allergic, moderate, which is the beginning of an anaphylactic response, and severe, also known as vasovagal. The severe, obviously, would be life-threatening. Okay? The procedures that we do for the evaluation of the GU system. First we're going to talk about is excretory urography, or the IVU, or IV urogram, or intravenous pyelogram. I would say that these are less frequently performed nowadays. I did them when I was an X-ray student. They are very carefully timed. I had an angry older X-ray tech who ran that X-ray room like the Navy, and if I didn't get my contrast injected in a minute to get my initial image, I was in very much trouble. So I had to push very thick contrast very quickly into an IV that I started so that I could get my first image, which we'll talk about in just a minute. Sorry. So excretory urography. It is a true functional test. Why? Because we are giving contrast media into the bloodstream and waiting for the kidneys to actually functionally filter that contrast media out, okay? The contrast media is rapidly removed from the bloodstream and excreted completely by normal kidneys, okay? Purpose is to evaluate the collecting portion of the urinary system, to assess the functional ability of the kidneys, and to evaluate the urinary system for any pathologic or anatomic abnormalities. You can do all three of those with an IVU. Preparation, they're going to have a light meal before the procedure. We don't want them full of, all-you-can-eat buffets or soup, salad, breadsticks, okay? Light meal the evening before for a couple of reasons. We don't want them to be full of poopy. It's going to obscure our visualization of the region of their kidneys, but we also want to be sure that they're not full of food just in case they have an allergic reaction, okay? They may also be given a bowel cleansing laxative for the same reason. We want the poopy out of the way. NPO after midnight, minimum of 8 hours. Again, so we don't have anything obstructing, and so there's no, we don't want them vomiting if they have a reaction, okay? Enema on the morning of the exam is part of the preparation. Again, clearing out so we can optimally visualize the kidneys. And the patient should pee just before the exam. Why would they do that? To empty the bladder, because we want everything that we see to be the contrast media, okay? Bladder that is too full could rupture. That's also another reason. If they have pee in there and we're filling them up with more contrast, it could rupture, especially if we're doing a retrograde urogram where we're filling their bladder with contrast through a catheter, okay? And again, urine already present in the bladder would dilute our contrast media. Questions on any of that? Okay. For this procedure, we could also, if we really wanted to take a longer detailed look at the kidneys themselves with contrast media, we could use what's called ureteric compression. We enhance the filling of the pelvic calyceal system. Very fancy word for saying that we're going to put a strap right across the abdomen of the patient while their kidneys are filtering out that fluid. These are terrible kidneys. They look nothing like real kidneys. We're going to put a strap right here to basically block off the ureters just distal to the renal collecting system or the renal pelvis, okay? Yes?
I thought it was the 7 floors that you were trying at first. Like Dopey's ears. I started laughing and I was like, oh,
All right, so for IVU, we're going to start with a Scout KUB. And after we inject that contrast media, this is incredibly timed. One of the most precise and quick procedures that we do in terms of imaging. We have to be very on it. We do the nephrogram. The nephrogram is when the kidneys start filtering that contrast media out of the blood. We take what's called a nephrogram. It is a 1-minute picture of the kidneys. After we finish that injection, we have to take that picture within 1 minute, okay? Otherwise, it's already passed out of the nephrons in the kidneys, okay? Angle 10 degrees or less, producing large section of tissue in relative focus. Remember when we had that wonderful conversation about tomography? The IVU is the procedure that we would use tomography for. Okay, we're taking slices of particular sections of the kidneys, okay? So angle 10 degrees or less to produce large, thick sections of the kidneys on each tomo slice. Don't worry, you'll probably never see this in actual practice, but just in case, we're going to talk about it. The CR for the nephrogram is between the xiphoid process and the iliac crest, which is where the kidneys live, okay? Bottom of the cassette is at the iliac crest. We're not going to talk about this too much because it's not even on your positioning final. Time of the injection, we take that image 1 minute after the start of the injection. Again, we want to catch the contrast in the nephrons. What is your problem? Question.
No, you're doing
Great. I'm glad you think so. After that, we'll do a 5-minute image, which is a full KUB, 10 to 15-minute image. Basically what we're doing is we're watching the contrast media filter from the beginning of being filtered out until it starts to be drained down the ureters to the bladder. Okay? Yes?
When you mean like 5-minute image, you mean like you're taking an image at like 5 minutes?
At 5 minutes. After we finish that injection, we're going to take a 5-minute image. Yes. Because we're going to see something very different. We're going to see that contrast starting to filter into the renal pelvis and start to filter down the ureters. Okay? 20-minute obliques, LPO, and RPO at 30 degrees, not 45. Again, we want to see those kidneys in profile. So 30 degrees is all we're going to rotate, okay? Blah, blah, blah. That's good for that. PA or prone projection as a post void, okay? So after they've drained all that contrast out, they're ready to pee, we let them pee, then we do our post void to make sure that contrast got out, okay? Or to see if there's any reflux when they pee, okay? Questions? Have passing familiarity with that, okay? Retrograde urography, this is different. This is a non-functional examination. Why is it non-functional? Because we are placing a catheter and filling their bladder up retrograde with contrast media. Stay with me, Isaiah. It's a non-functional examination of the urinary system during which contrast is introduced directly retrograde or backwards into the bladder, okay? There's also retrograde cystography. That is a non-functional radiographic exam of the urinary bladder. Similar, we're going to place a catheter and fill their bladder with contrast media, okay? No patient prep is required, but the bladder should be empty before catheterization. And although no prep is required, I would probably still have the patient go to the bathroom to poop and pee to make sure that there's nothing obstructing our visualization of the bladder, okay? Contrast is allowed to flow in by gravity. We're not going to place the contrast any higher than 18 to 24 inches above the table. May require 150 to 500 milliliters of contrast to fill the bladder. The positions for retrograde cystogram are an AP with a 15-degree caudad angulation and bilateral posterior obliques. Mr. Ubalde was very nice to you guys. He's only doing the AP and one oblique. Yes. Yes.
So we're placing the catheter?
No. Typically a radiology nurse will place the catheter if the radiologist doesn't do it themselves. We don't have that in our scope of practice to place catheters. And yeah.
For the urography, it says for the other one, the cystogram,
yeah.
was iodinated.
Iodinated contrast for all these. Always iodinated. If we're looking at the urinary system, it's always going to be iodinated contrast.
So what's the distinct difference
Between what?
between urography and the cystogram?
Urography is the overall study of the urinary system. Okay, cystogram is a focused visual or focused study of the bladder. Cysto is the medical term for bladder, okay? Or vesico. VCUG. If you are lucky enough to work at a pediatric hospital, you are going to be inundated with VCUGs. When I worked at my pediatric hospital in DC, would do anywhere from 5 to 10 a day. So lots of crying kids because catheterization is not comfortable. It is an exam that provides a study of the urethra and it evaluates the patient's ability to urinate. Therefore, this is a functional study of the bladder and the urethra, okay? What we're looking for is something called VUR, or vesicoureteral reflux, okay? Fun way of saying we want to see if when the patient is voiding, contrast media flows back up the ureters toward the kidneys, okay? The reason why this is important is because if urine can backflow up the ureters, that predisposes patients to a urinary tract infection, which if it can go to the kidneys, means it can become systemic, okay? Very bad. So we did those a lot. Also, on little boys, on their urethra, because it's very long, they can have what's called posterior urethral valves, which is a congenital flap of tissue in the posterior part of their urethra that we don't really see when they have a catheter placed. We place the catheter, it pushes the valve out of the way, no problem, we don't know it's there. But the main part, one of the main parts of a VCUG is the voiding. We pull that catheter out to see if the patient can void on their own. If we pull that catheter out and the little boy can't pee, he has posterior urethral valves. Okay, that's a surgical fix. He's got to get that tissue removed so that he can pee normally. Okay. Also, because boys have a longer urethra, we always image their urethra in an oblique. Girls, because their urethra is about that long, we can image theirs in an AP. Okay? Questions? Anything to add? Great. Retrograde urethroplasty. This is performed on male patients to demonstrate the full length of the urethra. Contrast media is injected via syringe in a retrograde fashion into the distal urethra until the entire urethra is filled with contrast. There is a clamp. Sorry, gentlemen, we're all going to love the look of this. There's a clamp that has little things on it like that. Grabs the glands of the penis, and there is a little catheter on it. So it grabs the end, and the catheter injects the contrast media in. Are we all crossing our legs now? It's called a Brodney clamp. Okay? Okay, so with that said, any questions on any of that? Nowadays, I would say a lot of hospitals are trying to get away from doing a lot of radiologic studies of the urinary system. We have MRI, we have ultrasound. Ultrasound is very useful at looking at the kidneys and the urinary system. Okay? Have the patient drink a lot of water, fill their bladder up with pee after drinking that water, you can easily scan it with ultrasound. So the positions that you need to know. For the cystogram for next week, it is an AP 14 by 17. CR centering, 2 inches superior to the pubic symphysis with a 10 to 15 degree caudad tube angulation. Easy peasy, okay? Posterior oblique position, RPO, with a 30 degree rotation of the patient, okay? Centering again, 2 inches superior to the pubic symphysis, 2 inches medial to the ASIS.
The AP is an axial?
The AP is an axial, 15 degrees, yes. Okay, questions on that?
So if we pull this card.
And sorry,
Go
real
ahead.
quick. I would say the RPO is a 10 by 12 because the positioning, the centering is a little more specific on that one. So I would go 10 by 12 on that, okay? Yeah.
So the 10 or 15 degree conic intervals, the same for both men and women, is not different like how we did.
Same for both. Same for both. Question.
What would you say the 10 by 12?
For the RPO, for the posterior oblique position. I'll look at my notes to make sure that's right. But I think 10 by 12 sounds right because you're centering 2 inches superior to the pubic symphysis and 2 inches medial to the ASIS, which makes it more focused, more specific centering.
Then why the 14 by 17? I just said
14 by 17 for the
Because
AP only.
it's
I think you're
one.
looking at the whole, and because you're smearing it
okay.
down a little bit.
Okay.
Questions on that? So just those two for the cystogram. For the VCUG, 10 by 12 lengthwise. Obviously you can't shield. For males, 30 degree oblique into an RPO position to lay the urethra on its side. Females, perpendicular to the symphysis pubis. You're looking at that very short female urethra, okay?
Does that AP have an angle as well?
Uh,
For the voiding one?
no,
Okay.
not for VCUG.
Just-
Straight down.
Just for the cystogram?
Straight down, yep. Straight down for the VCUG. And for males, I would say it is also centering. Let me see if I can get specific on that because it's not on this sheet.
It'll probably fit in the book on the position.
Yeah. Questions on any of that?
And then if we pull the cystogram card,
You're going to do the AP and the RPO.
and then what about the voiding? Do we add the voiding if it's
No.
male or female?
If you pull VCUG, you just do either, it will say either male or female, and you'll just need to do the positioning for either one of those.
Oh,
Okay?
Let me get that one. On that point.
I would say for the male, it's also centering at the symphysis pubis and that RPO for the VCUG. Okay?
It says portrait in the book. It says 10 by 14 for the art.
So the RPO and AP are both portraits. They're just two different sizes.
Yeah. 10 by 12, yes. Yes.
The thing is, when you do a VCUG on a male, you're going to center, well, the radiologist will be centering over where the penis is laying on the leg. But for our purposes of your final, just center at the pubic symphysis, okay? And put them into a 30 degree RPO. Okay. Tomorrow we'll talk